Good afternoon. Thank you, Dr. Shahab, for the opportunity to present a brief synopsis of what we learned about structural heart disease over the last year. Again, it's a pretty large topic, as you can imagine, but I will try to fly through it. Would ask you guys to put your seatbelts on, and hopefully we can get this through things together. Looking at when I was putting this talk together over the last week, I figured that, if you look at these society meetings, the last one being the TCT would probably be the most updated one, encompassing and the most recent fresh data, and this is the source that I use today. So a lot of the slides today will be used from our TCT, and I encourage you all to get membership in the TCT MD website because it's a very rich data. My colleague presented some of this data that was presented, specifically the Matterhorn study, so I'll skip some of these, but these are some of the items that we're going to be discussing today, and we'll go briefly through them. So a lot of data was presented in the structural heart arena, and it started off with the early TAVR and the AVATAR. So this is a study that looked at really asymptomatic aortic valve stenosis, severe, and is there a role of early intervention now? Just to remind you, although we all know that the data on the severe aortic stenosis for symptomatic is a done deal. This is a no-brainer. They meet the guidelines, and this is no history, no surprise. Goes back to the famous graph of Dr. Eugene Braunwald, who shows us that the symptomatic patients will have a very bad outcomes in terms of mortality, and usually they would die at average age 63, and depending on what symptoms are, whether angina, syncope, or heart failure, they each carry their own problems. However, symptoms are often not easy to attain in patients who are elderly, who has multiple comorbidities. Additionally, those patients who have received valvular interventions continue to have heart failure and mortality despite the treatment. So really the question is whether we need to do early TAVR may change the course of these patients before waiting for the symptoms or the traditional symptoms of syncope, angina, and heart failure. And this was the premises of two randomized trials that were initially presented back in the days, about a year or two ago. This was about specifically talking about surgical AVR. And then the early TAVR looked at the most recent data presented at the TCT back in October, about 6 weeks ago, and also took on the discussion about the 5-year follow-ups after the AVATAR, which was aortic stenosis randomized to clinical surveillance versus surgical AVR. So you'll see between the early TAVR and the AVATAR two elements of two modalities. The 5-year data, the structure of the trial on the AVATAR is on the left of the screen, and then the structure of the early TAVR on the right. These are the baseline characteristics. What did we learn from AVATAR and early TAVR? Number one, preemptive intervention for asymptomatic severe aortic stenosis did result in less adverse clinical events. And this is clearly shown here in the composite endpoint with the AVATAR, 5-year follow-ups, and also in the early TAVR, where the green is the clinical surveillance and the blue is the therapy treatment. It also showed evidence of improved heart failure symptoms, as well as hospitalization for both trials, the surgical and the percutaneous TAVR. Lesson number two, preemptive intervention has not been associated with access, stroke, or mortality. And you can see here the two curves overlap between the clinical surveillance and SAVR and the clinical surveillance and TAVR. Lesson number three, patient underwent clinical surveillance in early TAVR. This is a very important message. Had a higher frequency of early conversion to intervention and converted because obviously of severe symptoms, meeting the guideline directed indication for TAVR. And if you could see here in the curve on the right of the screen, this shows the patients who were enrolled in the clinical surveillance. And in about 2 years, almost 2/3 of the patients converted to TAVR. And by the end of 5 years, everybody converted to TAVR. Now these are, the indication for conversion was clearly, and I should say converted to TAVR or SAVR, because those conversions were left to the discretion of the site, and they had to choose between surgical or transcutaneous. The symptoms were classified into asymptomatic, progressive, and advanced. And if you can look here, that almost 40%, and this is one of the take-home slides of this trial, that 40% of the patients who converted to treatment of the valve, whether surgical or percutaneous, actually represented 40% were from the high and advanced symptoms, and the other 60% were considered in the progressive symptoms based on the classification of symptoms. The conclusion, in low-risk patients with severe asymptomatic aortic stenosis, early TAVR, and AVATAR 5 years did confirm better clinical outcomes. Early TAVR extended that conclusion to older patients. Preemptive AVR aortic valve replacement led to a significant reduction in unplanned heart failure hospitalization. And to me, this is one of the most important messages, that these patients in early TAVR who were randomized to the clinical surveillance, 70% of them within 2 years needed the replacement, whether surgical or percutaneous, despite close clinical surveillance, and about 1/3 those ended up having a severe progressive symptoms based on the symptomatology. Let's shift gear here, talk about role of TAVR in moderate aortic stenosis. Why moderate aortic stenosis? Well, moderate aortic stenosis have shown always that they do carry and do face a high mortality. And it's shown clearly in the Australian data here and in the data of 1.6 million from the US, that the moderate AS are not mild or benign patients. Specifically when it comes to low EF. And those patients, if you have a moderate AS and have low EF, you have a bad combination. And it's been shown in the death from cardiovascular causes that almost fourfold increase in the death of cardiovascular causes are in those who have low EF versus those who have normal EF. Now, we all know that heart failure, reduced ejection fraction, benefits from the medical neurohormonal modulation of the afterload reduction. So what better can you offer these patients than an actual mechanical relief of their afterload to complement their medical therapy? This was the basics of the study, which was the TAVR on load, randomized to TAVR versus clinical surveillance. Now, what they did here, they initially had a protocol of 1 year, and then they revisited the protocol due to financial constraints and low enrollment. They said, we're going to go to a longer follow-up to have a lower number of N. And that may end up hurting the data, and I'll show you that later on. These are the inclusion criteria. Again, you had to have a low EF. Now, the fate of the clinical surveillance arm. So this is the people who were monitored. As you can see, almost 40% of them, north of 40% of them, end up going with TAVR. First year, 2 years, second year, third year, fourth year. And here you'll see that the majority of about 43% of the patients who were in the moderate aortic stenosis conservative arm end up leading to TAVR because of progression of symptoms. Now, using the methodology of the Frankenstein-Schoenfeld hierarchy here, you can see that if they looked at the data based on the longest follow-up, that the benefit was not shown between the interventional arm versus the conservative arm. But when they looked back and looked at the data from a 1-year follow-up, there was a statistical significant benefit in favor of the interventional arm compared to the conservative clinical surveillance. This is the MACE, this is the all-cause death, this is the Kansas City quality assurance. You can see that the overlap happens towards the end of the study on the conservative. That's not because conservative therapy improves the quality, but because of 40% of that patients, of those group patients, end up getting TAVR. So when you took out these patients, you can see that the quality of life is not improved, obviously, in the clinical surveillance, but it is improved in the surgical arm. Now, if you look at this curve here, you'll see that this is the curve of the patients who had clinical surveillance, and about 60% of those patients, and you can see it here, had end up receiving TAVR within 3 years. The other 40% did not receive it because they did not make it alive. So when you look at the data of this high, moderate, symptomatic aortic stenosis with low EF, the majority of them, in 3 years of the completion of the study, they either received a TAVR or they died. The conclusion that the TAVR in moderate AS did not affect the outcomes because of if you followed up by the median follow-up of 23 months. However, if they did the 1-year follow-up, there was some meaningful improvement. During the trial, 43% of the clinical surveillance arm did undergo TAVR. Now, the investigators also concluded that cardiac damage framework may identify a broader patient's phenotype for moderate AS who may benefit from upstream TAVR, and this is going to be looked at the PROGRESS and the EXPAND TAVR 2 trial. What about aortic regurgitation? So Alani 2 looked at aortic regurgitation, and this is a single-arm study. They published in the TCT last month their 2-year data. So last year they published the 1-year and 30-month data, which had met, it's a single arm, which had met the performance goal set for it, and last month they represented the 2-year. This is the valve, or the Jenna valve, that represents, really grasps on the leaflets of the aortic valve and gives you the option of fixes the problem. Now, in the multi-center Alani trial, they reported 30-day and 1 year, and these were single arm compared to pre-specified performance goals. 2 years represented a year later. Not a lot of patients were lost to follow-up. These are the outcomes. The primary efficacy was 7.8 with a confidence intervals upper side of 12%, much below than the pre-specified performance goal, and hence meeting the non-inferiority. You look at the mortality at 1 year and the mortality at 2 years did increase, still below the 25%. And you look at the cardiovascular mortality at 1 year and 2 years did not change, which suggests that the majority of the mortality that happened between year 1 and year 2 were non-cardiac. And here you can see the outline where 13 mortalities happened, 11 of them were non-cardiac. What about stroke? No difference. What about hemodynamics? This is a very important. You can see at 1 year the effective orifice is the same, and I am shut down. That cannot contain. All right. Well, thank you very much.